Welcome, everyone. Thank you for tuning in. My name is Brooks Roach. I am a diabetes education specialist with Diabetes Canada. And I'd like to begin by welcoming you, our viewers, and acknowledging that the land from which I'm calling is the traditional and unceded territory of the Mi'kmaq people. So wherever you are joining this webinar from, I would invite you to just take a moment and reflect on the traditional traditional inhabitants of the lands we now call Canada. I'm really excited to be with you today and to present this really exciting collaboration that we've been developing with a wonderful partner, the Canadian Liver Foundation. And the intent of this webinar, as you'll hear, is to discuss some of the fascinating intersections and present you with some actions and strategies, recognizing the link between liver disease and diabetes. And with that, I'd like to hand it over to my colleague from the Canadian Liver Foundation, Nem, take it away.
Thank you, Brooks. Hello, everyone. Good afternoon and good morning and good day for everyone who is joining us today for this wonderful upcoming webinar. As Brooks did mention, my name is Nem. I am one of the senior managers of support and education at the Canadian Liver Foundation. I would also like to acknowledge that our national office for the Canadian Liver Foundation in Markham, Ontario, is situated upon traditional territories of the Anishinaabe peoples and of the Haudenosaunee peoples covered by the Upper Canada Treaties. We are joined today by two wonderful experts. We have Dr. Mark Swain, Professor of Medicine and Head of Division of Gastroenterology and Hepatology at the University of Calgary, as well as Dr. Anne Doyle, endocrinologist and Associate Scientist in Clinical Epidemiology at the Ottawa Hospital, and Assistant Professor of Medicine at the University of Ottawa. Welcome and thank you both for being here. So as Brooks mentioned, we are going to be diving into an important conversation evaluating and discussing relationships between liver disease and diabetes. And our experts will be answering some key questions that we've been hearing from patients. We'll also be taking questions from our viewers, and some questions have already been submitted. So thank you everyone who has submitted questions ahead of time. And you can also ask any of your questions by replying in the comment feed below. Without further ado, I will be turning the mics over to our experts.
Great, thank you for inviting me today. I'm Anne Doyle, and although I'm an endocrinologist here in Ottawa, I have had an interest in chronic liver disease probably for the last 10 to 15 years. My interest started out initially with infectious liver disease, so hepatitis C and specifically hepatitis C, and the relationship between infectious liver disease and the incidence and prevalence of diabetes. And that got me thinking about how really in endocrinology and diabetes management, we really don't pay much attention to the liver, and got me shifted my focus. I think also too, as we started finding treatments for hepatitis C, there was less interest in that area, but it shifted my interest more to metabolic liver disease and the association with diabetes. And so I'm happy to be here to talk with Dr. Swain about that today, and answer any questions that anyone may have.
And hi everyone, I'm Mark Swain. I'm in Calgary, and actually, like Marianne, my interest traditionally was more in sort of infectious types of liver disease and autoimmune types of liver disease. And in fact, fatty liver disease was something that was actually really it was kind of ignored actually in the liver world for a very long time, but it's become quite clear that not only is it an entity on its own, but it's also a driver for other forms of liver disease and often makes them more aggressive. But also it's become very clear that it's linked to mainly type 2 diabetes, and so this is a natural kind of discussion because type 2 diabetes and fatty liver disease are often not talked about at the same time, but in fact they should be, because as you'll see as we go through our discussion today, is that they intertwine very robustly, and in fact they need to be discussed really together. So thanks for joining us.
Great, thank you, Dr. Swain. So I'm going to just start with some broad facts about diabetes in Canada. I think over the last 2 years, we've really focused on COVID, but in all of that, there's been another silent disease that's been grumbling along. And I think we need to take just a minute to kind of think and look back at some of those numbers. So interesting, 1 in 3 Canadians in Canada, so about 11 million Canadians are actually living with diabetes or pre-diabetes today. And that's an enormous amount of people. And the burden on our healthcare system is phenomenal. And we know that there's a lot that we can do to prevent this. And that a Canadian is diagnosed every 3 minutes. So in this talk today, during this hour, about 30 Canadians will be diagnosed with diabetes. And again, this being that it is a preventable disease, really there is a lot more that we can do to mitigate that. About 1.5 Canadians, 1.5 million, sorry, not 1.5 Canadians, 1.5 million Canadians actually have type 2 diabetes and don't know it. And that's because it really is a silent disease. People can have high blood sugars for years and years and years and not be aware of it. And then there are about 6 million Canadians that are living with pre-diabetes, half of which will go on to develop type 2 diabetes. But with appropriate preventative care, we can prevent that. We can change that course. And the real concern with diabetes is that it's the complications that come from it and come from the high blood sugar. So we know that it's a leading cause of blindness. It causes 30% of strokes that we see, 40% of heart attacks, 50% of kidney failure that requires dialysis, and then 70% of all non-traumatic leg and foot amputations. So a real healthcare concern that we can do more to change the course of the disease. So I'm going to take just a little step back here and just go back to some basics about what is diabetes. Diabetes is elevated blood glucose levels. And to understand that, we really need to think about, well, what is plasma glucose? And it's basically a fine balance between glucose entering the circulation and then glucose being removed from the circulation. So what we eat versus the energy we expend. And the body requires a constant source of energy. So even though we're sleeping, our body is still using glucose in our blood, and we only eat intermittently. So that balance is regulated very tightly, in fact, by hormones that are secreted from the pancreas. So we have insulin, is which we talk about most often, but also glucagon. And insulin and glucagon work together to make sure that that blood glucose level is well controlled. But there's also a number of other players that we need to consider when we're talking about diabetes. So can we move on to the next slide? So some of the key players are the brain, which in fact uses a significant amount of our blood glucose levels or amounts, but it's able to use glucose independent of insulin. It's the only organ that is. Then there's the pancreas, which which is a key player in regulating glucose metabolism through the secretion of both insulin and glucagon, and again, that fine balance. Then we have our muscles, which are important in terms of when we're ready to exercise and be active, then our muscles are able to use that energy, also able to store some of that energy, also able to use some of that, the circulating blood glucose with independent of insulin. So the more active you are, the more your body will be efficient in using that circulating glucose. The kidney is a really important player in terms of excreting glucose. So when glucose levels get high, the kidney is able to excrete more glucose. And then adipose tissue, important in storage. When there's high levels of glucose around, our body is able to convert that and store it for a time where we may need that, and store it as adipose tissue. And then what we're most interested in today is the liver. And that's probably the player that's least talked about, but probably the biggest player in glucose metabolism. So not only is the liver key at making sure that the body has the proper glucose levels it needs when it comes time for activity, energy is needed, but it's also able to store large amounts of glucose. And so probably one of the biggest key players, but often neglected and not focused on as much until recently. I'm also going to just take a step back, and we often talk about diabetes being as if it's all one disease. And honestly, until recently, we have actually treated both type 1 and type 2 diabetes as if they are one and the same. And I'll get into the rationale for that. But I think it's important to realize that there are two separate diseases. And although they're both referred to as diabetes, two very separate diseases. So type 1 diabetes is actually an autoimmune disease where you get destruction of the beta cells. And beta cells are the cells in the pancreas that are important in producing insulin. And when those get destroyed, the body's no longer able to produce insulin and no longer has the insulin around circulating that is needed to help the body and the cells in the body, the liver, take up those circulating glucose levels. And as a result, the glucose increases in the blood and then becomes toxic to the circulating cells and organs. The exact cause is really not well understood. It's probably a combination of genetic and perhaps environmental factors that are contributing to this. And so really this is an insulin deficiency problem, and the treatment for this is insulin. In contrast, type 2 diabetes, the body does make insulin. The cells that are making it haven't been destroyed or anything, but the body can't use it properly. It also then starts over time, those cells may start to fail and produce less insulin. And there's insulin resistance, but also an insufficient production to overcome that insulin resistance. When we're talking about causes or risk factors, we know that as people get older, this seems to be more prevalent. Obesity definitely contributes to this. We know that a sedentary lifestyle can contribute to it. There's definitely certain genetics, and it's probably multiple different genes that are acting simultaneously. And then ethnicity definitely contributes to it. The interesting thing about this is that with lifestyle modification, weight loss, certain oral medications and insulin, we can change that. And that's our treatment. So it's not solely, oh, your insulin isn't working, we need to give you more. Well, which is what we sometimes do, but that isn't our main treatment, and it isn't our go-to treatment. Type 1 diabetes is really not preventable at this point because we don't fully understand the cause, and it really only accounts for about 10% of the cases. In contrast, type 2 diabetes is preventable in many cases, and it accounts for about 90% of diabetes cases.
Marianne, pardon the interruption. We just have a few folks who are commenting on Facebook that they're not able to actually see the live feed. So if you don't mind, we're just going to pause for a moment and reconnect to that live stream.
Sure.
There's not a Zoom webinar without a technical issue. Okay, folks, it looks like we are back. So I will hit next slide and hand the reins back over to you. All right.
All right, great. So I just was talking about the differences between type 1 and type 2 diabetes. And really our focus today is going to be on type 2 diabetes and the association between type 2 diabetes and metabolic liver disease, because they're probably, and Dr. Swain will go into this a little bit more, but either intertwined or related, or maybe even spectrum of the same disorder. So that's what our focus is really going to be on. And so when we're looking at, and this is just a little bit of a diagram to sort of explain what's happening when we have type 2 diabetes. So as I mentioned, there's insulin resistance. And as a result, you get decreased uptake of glucose in the body. So a decreased uptake in the muscle, decreased uptake in adipose tissue. You get higher levels of glucose circulating. You also have beta cell dysfunction. And so the beta cells, the insulin secreting cells in the pancreas, are not able to overcome this resistance. And as a result, there's less insulin. There's still insulin, but there's less insulin circulating for the level of the the blood sugars are at. And as a result, all of these factors contribute to higher blood sugar levels. The liver is also not recognizing necessarily that there is these high levels because the body is in need of glucose and not entering the cells. So it actually also leads to increased glucose output. So there's basically dysregulation between the pancreas, the liver, the muscle, and adipose tissue. So all of the key players in the body or in glucose metabolism. And why does this matter? So we know that with higher blood sugar levels, and this is important in type 1 and type 2 diabetes, but when the blood sugar levels are high, over time, these high levels of glucose are actually toxic to the cells and organs of our body. And as a result, this leads to a lot of macrovascular complications. So it puts people at higher risk of stroke, heart disease, and hypertension. It leads to peripheral vascular disease, so narrowing of the blood vessels that supply the feet and toes and fingers and arms. And as a result, can lead to increased risk of infection, also increased risk of amputation. There's also microvascular complications. So the smaller vessels that supply the eye are quite sensitive to high blood sugar levels. And as a result, this can lead to changes in the retina, so the back of the eye, as well as increased risk of cataracts. High circulating glucose levels are also quite toxic to the kidneys. And as a result, this puts people at risk for renal disease. And over time, slowly the kidneys start to fail and they're no longer able to function and to clear the blood like they should. And patients end up needing dialysis. It also destroys the small little nerves that we depend on for sensitivity in our feet and our hands and our toes. And as a result, again, leads to risk of infection and less risk of injury to the feet and subsequently amputation. And we know if we control blood sugar levels, and so our goal has been with management of both type 1 and type 2 diabetes is to lower those glucose levels. And for the most part, we do that through a number, well, with type 2 diabetes, lifestyle modification, and then medications. And I'll go into a little bit more detail in a moment after we hear a little bit from Mark or Dr. Swain about why this is important.
Thanks, Marianne. So when you saw that overview that Marianne showed, the picture of the complications of type 2 diabetes, it really that's a traditional picture, and that liver is not actually included on that. And so hopefully we're going to I guess stress today that the liver actually is something that's intimately involved in type 2 diabetes. And what happens in the setting of a number of things, but type 2 diabetes, one of them is that you can develop fat in the liver. And if you look on the left, the liver becomes kind of yellow and a bit swollen, where normally it's kind of pinky. And if you look at in a liver biopsy, sort of microscopically, the normal liver is on the left, and you can see nice little sort of liver cells which are pink, and they've got the nucleus, which is the bluey part in the middle, and they're all in little chains, like little blocks that are built in chains, and the blood flows between them, and that's where the exchange of nutrients happen. They're so important to metabolism. But if you look on the right, that's a liver someone that has, or a biopsy from someone that has fatty liver. And you can see the liver cells are swollen, and the white areas that look like balloons, they're actually cells that have been expanded to be a balloon shape by fat that's been deposited in the cells. And that fat can actually lead to liver injury. Next slide. Next slide, please. Yeah, thanks. And so, first of all, so what is NAFLD? I mean, this is a word that we'll use today, and we'll use the word NASH as well. And so it's important to define them. So NAFLD is a short form for what the term non-alcoholic fatty liver disease. And so it means it's essentially a a diagnosis of exclusion. So you remove the other cause of liver disease, including there's a certain cutoff amount of alcohol consumption on a daily basis that once you go over that level, then that drives what we call alcohol-related or alcoholic fatty liver disease. And how much alcohol that is quite hotly debated. However, you also can develop something called NASH. And NASH is short form for non-alcoholic steatohepatitis. And that is a very fancy term, but essentially steato just means fat, and hepatitis means inflammation. So this means when the fatty liver has become a condition where the liver is inflamed and being damaged. Next slide. And so when one's talking about NAFLD or non-alcoholic fatty liver disease, it's important to recognize they're actually talking about a spectrum of liver diseases. And that ranges from fatty liver, as I just showed you that picture, to NASH. So NASH is the fat accumulating in the liver that's associated with inflammation or damage or destruction of liver cells. And that destruction of liver cells can lead to scarring in the liver. And then if you get enough scarring in the liver, that's what we call cirrhosis. And if you have enough cirrhosis, then you can get liver failure and also and need a liver transplant, or it's a cause of liver-related death. But also it predisposes people to developing liver cancers. And once you have cirrhosis, you have about a 3% chance per year of developing a liver cancer. But uniquely in fatty liver disease, which is different than all the other, pretty much all the other liver disease, except for maybe hepatitis B, people can go just from having fatty liver without cirrhosis, even to developing liver cancers. And the pictures at the top here just shows, if you look at the one on the right, the pink is liver cells, and the blue is scar tissue. And you can see that the scar tissue, or the blue, is surrounding the pink to make it look nodular or like lumps. And that lumpy bumpiness is what, when people talk about cirrhosis, that's what they're referring to, is this sort of the outside of the liver and inside, all through the liver, becomes lumpy bumpy and hard. Next slide, please. And so what are the main causes of non-alcoholic fatty liver disease? Well, as Marianne said, and this is often not, I think has been poorly recognized, is that diabetes is the main driver, and obesity. Those are the two critical drivers of non-alcoholic fatty liver disease. Although these other things are caused, there's some medications that can lead to it. There are some genetic changes that can drive fatty liver disease. People that have high cholesterol or high triglycerides, which is another fat in the blood, they can also develop fatty liver disease. And not usually an issue in Western countries, but rapid weight loss can also rarely cause fatty liver. Next slide. And when you look at fatty liver, most people say, oh, I've never heard of fatty liver disease. I've never heard of NAFLD or NASH. But in fact, if you look in North America, so with the red circle around, you can see about 25%, so 1 in 4 people has fatty liver disease. So it's extremely common. It's growing every year. The number of people in our society that have fatty liver is growing. And when you look at NASH, so this inflammation of the liver that's associated with fat in the liver, that's also associated with the development of scar tissue, that affects about 2 to 3% of the general population. Next slide. So what's the relationship between type 2 diabetes and NAFLD? Next slide. So Marianne showed that the liver is kind of plays an important role in insulin sensitivity, insulin metabolism, glucose metabolism, but there's growing evidence that there's a link between type 2 diabetes and NAFLD, and that is that the resistance to the effects of insulin in the body, which is really, as Marianne said, is the hallmark of type 2 diabetes. So the tissues don't respond to insulin normally. That actually also leads to fat accumulation in the liver, so the steatosis, or non-alcoholic fatty liver. And when you look at people that have type 2 diabetes, there's a spectrum of studies that looked at this, but between 45 and probably closer to 75% of people with type 2 diabetes have NAFLD, or non-alcoholic fatty liver disease. And this fat that accumulates in the liver in the setting of type 2 diabetes, as I mentioned, can lead to inflammation, or NASH, and liver damage and scarring. And when you look at people that have type 2 diabetes, they're more, and they also have NAFLD, they're more likely to have NASH, so this liver inflammation. They're more likely to have liver scarring, and they're more likely to progress to advanced liver scarring, so cirrhosis, and also to develop liver cancer. Next slide. So and the flipping it around, what's the link between NAFLD, or having fatty liver disease, and type 2 diabetes? Well, people who have NAFLD, so on an ultrasound they've shown to have fatty liver, they're more insulin resistant than those that don't have NAFLD. And when you look at people that have NAFLD, they are 2 to 3-fold more likely to develop type 2 diabetes over the next 5 years than those that don't have NAFLD, even if they're not overweight. And people with a higher levels of fatty liver, so more steatosis, they're even more likely to develop type 2 diabetes. And so the more fat one has in the liver, the more likely they are to develop type 2 diabetes over time. And that risk is increased even further if they also have associated liver scarring. So as I think Marianne alluded to, and I think that picture that showed that individual with the complications of diabetes, traditionally the approach to finding and managing NAFLD in people with type 2 diabetes has really been one of, I don't see anything here. And the reason why, I think, is because there was, I think, very limited understanding of it. I think there was a perception that it was a benign thing, that would come and go and didn't really drive any sort of adverse liver outcomes. And so it was traditionally ignored. Next slide. So what's the reality? Is it that we're making a big thing out of nothing, and this is actually just how we were managing this in the past is the right way, or is this the zombie apocalypse, and this is something that is a crisis? Next slide. So when one looks at liver disease, this kind of shows what the liver on the left is a normal liver. That's F0, means no scarring. And as you go to the right, that's what, as a liver specialist, what I'm most concerned about is you start to develop scarring in the liver. And when you get to F4, that's cirrhosis. And when you get to cirrhosis, then you're much more likely to develop liver cancer or develop liver failure. And when you look at the drivers that move people from the left to the right, type 2 diabetes is one of the key drivers of that scarring in the liver and that progression. And that when you get that liver fibrosis, that's a key driver of poor outcomes. So the question is, if 45 to 75% of people with type 2 diabetes have fatty liver or NAFLD, how do we actually find those with significant liver scarring so that may benefit from seeing a liver specialist, recognizing what Marianne said, was that most people are going to have these other issues, which are the things that are going to impact their lives more than fatty liver disease. Well, except the people that have significant liver fibrosis. Next slide. And so one of the things we need to get better at, and this is something where I think people who manage individuals with diabetes and people who manage liver disease, especially starting at a primary care or family doctor level, is we need to develop and use clinical care pathways and case finding strategies, so that we can look at a large group of people that have type 2 diabetes that are out in the community seeing their family doctors, and make sure that the people with NAFLD are streamed in the most appropriate care streams. And usually that will not involve a liver specialist. It will involve someone that's helping them manage their cholesterol better, their sugars better, and things like that, because most of them will not have significant liver disease. Next slide. And I just want to highlight one pathway that we developed in Calgary, and through this pathway that is really run by the family physicians in Calgary, we've been able to funnel individuals that are found to have fatty liver. Some will have type 2, many, about half end up having type 2 diabetes, and another sort of 20% are pre-diabetic. We're able to funnel those in to see a liver specialist if they're found to have significant liver scarring based on some very sort of tests that can be done within primary care. And so it ends up that over 90% of the people that have fatty liver never need to see a liver specialist as part of this pathway. Next slide.
So I'm going to jump back a little bit to type 2 diabetes and how we approach it and what our goals are. So with obesity and sedentary life being a huge component, a huge risk factor for developing type 2 diabetes, lifestyle modification is #1 in terms of treatment. So we encourage people to be active, to make sure that they're making good dietary choices, and I'll get into a little bit more. And hopefully with those lifestyle modifications, there'll be some weight loss. And in people that we're not able to achieve or to improve blood sugar levels with either of those, then we consider medical therapy. There's oral medications, there's injectable medications, and then there's insulin therapy. And I'll go into a little bit more about each of these. Next slide. So lifestyle modification. And on the next slide, I have a little bit more detail, but it really is about making good dietary choices. And patients will often ask me, well, what diet do you recommend? What should I be doing? We really encourage our patients to follow the Eating Well with Canada's Food Guide. So a balanced diet and everything in moderation. Is there one diet that's better than another? Really difficult to say. I often will tell my patients it's whatever diet or whatever food plan, because diet also to me sometimes implies that it's going to be a short-term thing, and that they can go back eventually to their old eating habits. So whatever food plan they can stick with and keep with, I think is going to be the most important and the most successful. In people who are overweight or obese, we do recommend a nutritionally balanced, calorie-reduced diet or food plan so that they do lose weight. And then an intensive behavior program, maybe combining dietary modification with increased activity. And what does increased activity mean? So for Diabetes Canada recommends a minimum of 150 minutes of moderate to vigorous activity each week. And that should be spread out over at least 3 days. So going out and doing a 2-hour walk one day of the week is really not the ideal recommendation or suggestion. Ideally, it's spread out over 3 days and no more than 2 days without exercise. It's also important to really reduce I know it's hard in COVID times where everybody's working from home and doing a lot of online meetings and things like that, but it is really important to avoid long periods of time being sedentary. So again, to be active for 30 minutes a day and then to sit for the rest of the day is not the ideal situation. So really important to be as active throughout the day as possible, and maybe breaking that up into 10 minutes 3 times a day, which can again be challenging, but is probably going to be more beneficial than just clumping it to all at the start or at the end of the day. Resistance training is also important, and it's recommended at least twice a week, preferably 3 times a week, in addition to the aerobic exercise. So really trying to be as active as possible. Next slide. And so in patients that aren't able to control blood sugars with diet and lifestyle and exercise, we do treat them with a variety of different oral medications to start. And the order of how we start this is really going to be dependent on what other complications the patient has. And we are really shifting towards a more patient-specific regimen. So I'm not going to really go into too much about when would we start this or when would we start that. But in terms of medications that we have medications like metformin that enhance insulin sensitivity. So they make the liver more sensitive to the insulin that's circulating so that the body doesn't need to produce more insulin, that the insulin circulating will be better recognized and function better. We have a medication like acarbose that actually inhibits uptake of glucose from the gut. We have other medications like secretagogues that actually cause the body to make more insulin. And then that insulin subsequently works on the liver to cause and other tissues to cause the body to use the glucose that's circulating. We have a newer class of oral medications and injectables. Some of them are injectables, some of them are orals. That are called incretin hormones. And these medications work at the level of the gut, and they cause the body to actually create more of GLP-1 hormone that is then circulates and has other effects outside of the gut and specifically on the pancreas. I'll get into a bit more detail about that to help the pancreas produce more insulin. We also have a new group of medications called SGLT2 inhibitors. And again, these work differently than all our other medications in that they reduce the glucose reabsorption at the level of kidney and cause the body to excrete excess glucose. Some older medications called TZDs, and these are also insulin sensitizer, not used very often these days because there's been some concern over cardiovascular risks, increased cardiovascular risks. And when all of these fail, then often we'll start to add insulin. And then again, that just causes the body to try and store more of that circulating glucose. What's unique about these newer medications, so the SGLT2 inhibitors as well as the GLP-1 agonists, is that they actually lead to weight loss. The SGLT2 inhibitors will actually prevent the reabsorption of glucose at the level of the kidney. So you're getting a loss of calories through the kidney and urine. This leads to decreased fasting glucose levels. Patients are less likely to have a rise in glucose levels after a meal. Their overall A1C, which is our long-term measurement of blood sugar control, is decreased, suggesting better blood sugar control. They've also been shown to have cardiovascular benefit, and not going to get into too much detail there, but important when we're also talking about NAFLD, because we know with NAFLD there's also increased cardiovascular risk, but these have increased cardiovascular benefit. And perhaps with the weight loss that comes along with this, is there a benefit on the liver? We don't know. More studies are needed, but there is the potential that unlike some of our other older medications that are causing the liver to store more, and perhaps maybe it potentially could be exacerbating some of the liver steatosis, perhaps these might actually have a benefit. GLP-1 agonists, as I started to mention earlier, work differently than all our other medications as well, in that they work to increase a hormone in the gut called GLP-1. This hormone has a variety of different effects. Locally, it causes a decrease in gastric emptying, so people feel full longer, they have increased satiety. It also works at the level of the brain to improve satiety as well, so people feel that they're more satisfied with less food, so tend to eat less. It works also at the level of the pancreas in that it increases insulin secretion. It decreases glucagon secretion, so it's causing the pancreas to work more effectively, more insulin circulating. It helps to better control blood glucose levels. It helps with those beta cells. So those beta cells that are producing insulin, it causes an increased number of beta cells. It prevents beta cells from dying off. It increases glucose uptake. And like the SGLT2 inhibitors, there's been studies that have shown increased cardiovascular protection. We know that weight loss comes along with this, and potentially with all of these benefits, improvements overall in liver steatosis. And I'm going to let Mark talk a little bit more about that, but there's been some preliminary studies that have showed that. And it's definitely encouraging and game-changing when we're thinking about how we manage diabetes. One of the other benefits of both of these medications is just that often we're able to use these medications and either get patients off insulin or at least reduce the amount of insulin that they're taking. And decreasing the amount of insulin that they're taking is also overall beneficial in terms of weight loss and in terms of the liver. And I'll hand it back over to Mark now.
Thanks, Marianne. So I'm going to switch the management now just to focus as a liver specialist. So I often focus more on the liver, which of course you can see how these interact, and we need to have multidisciplinary approaches. But the mainstay of treatment is really quite similar to treating type 2 diabetes, is lifestyle modification and targeting components of the metabolic syndrome. So obesity, hypertension, hyperlipidemia. Next slide. And even though as a liver specialist I have a tendency to focus on the liver, it's really important to recognize that the liver is not the biggest source of mortality or death in individuals with type 2 diabetes. It's the complications that really Marianne was talking about. So it's very important to have optimal control of diabetes, control the high cholesterol and triglycerides, to treat high blood pressure, and then to do weight loss strategies, which include low carbohydrate diets, and the keto diet's the big one nowadays, and low fructose. So fructose is the main sweetener in pop, and pop is a huge driver because humans don't metabolize fructose, and so it drives fat into the liver, which drives inflammation. Next slide. I just want to, there's a lot of discussion these days about the Mediterranean diet, and I think this is quite relevant to put here, because as Marianne said, I think the most important thing is to find, it's not a diet, it's how you like to eat that suits you, so you can actually eat a healthy diet. But when one's talking about weight reduction in the setting of NAFLD, you're really looking at about 7 to 10% to start to really see the beneficial effects on the liver, and around 10% to start to see beneficial effects with regards to scarring, 7% to see beneficial effects with regards to inflammation. And again, there's a really low carbohydrate, low fat, or different types of fat. And so olive oil is really a big driver of the Mediterranean diet. And again, reduced fructose, and the things that are listed here under the Mediterranean diet part: fish, vegetables, low sugar, high fiber. I just also want to put it out there that there's a growing epidemiological evidence that coffee drinking is actually beneficial for the liver point of view. And so if patients come to me and they're drinking coffee, I actually suggest they're even drinking more if they can. The important thing is to recognize that if you're drinking coffee and adding sugar, like a double at Tim Hortons, then that's not actually drinking coffee. That's drinking sugar with cream and a bit of coffee flavoring. And so it's really important to if you're going to drink coffee and get the beneficial effect from it, then you should use non-sugar sweeteners and try to use a low-fat milk or whitener. Next slide. So what are the future pharmacological therapies for this inflammation and scarring in the liver associated with NAFLD? Well, I just put this slide up to just show you that there's a ton of therapies out there. In fact, there's like almost 800 clinical trials going on across the world now for fatty liver disease, because this is such a huge issue. And they mainly target things, these different categories: metabolic, antifibrotic, anti-inflammatory. I'm just going to focus on two that I think are relevant because they're the furthest along, and I think probably the most exciting right now. Next slide. So what are these liver-directed pharmacotherapies for patients with NAFLD and NASH, the majority of whom are going to have type 2 diabetes or insulin insensitivity? Next slide. So the first one is this drug called obeticholic acid. And it's actually it's a bile acid derivative, and so we have in our bile in our bodies we have bile acids, and they can stimulate a receptor in our intestine called the FXR receptor. And this is a study that looked at it over 72 weeks, and what they found with this, so this is placebo in the blue, and then when you go to low dose in the green, the low dose in blue, and the higher dose in the pinkish color, you can see in the top bar that there's an improvement in scarring in the liver. So fibrosis is scarring, and this is a one-stage improvement. So you can see that there's actually this drug improves scarring in the liver. But interestingly, if you look at the bottom picture or bottom graph, it doesn't seem to change the inflammatory component. So it shows us that there's a differentiation between impacting the inflammatory component versus scarring, and we don't understand that very well at all. And it's relevant to the next slide, which is this drug that Marianne was talking about. Semaglutides is a GLP-1 agonist, and it's available to treat type 2 diabetes. And if you look on the left side, this is again treating with 72 weeks. The higher dose of semaglutide at 0.4 milligrams was significantly better than the placebo in the gray bar at making the inflammation in the liver get better. However, when you look in the right side here, it didn't seem to make any difference with regards to liver scarring. So again, they seem to be separate. And so the question about these type of drugs are, do they impact, if they impact inflammation over enough time, maybe 72 weeks isn't enough time, do they actually also have a beneficial effect on the scarring, which is really what we're most concerned about. Next slide. And that I think that's really the end of what I have to say. I think Marianne as well, and we're happy to take any questions and answer any of your thoughts or comments.
Well, thanks so much to both of you. I can speak personally, at least as someone who lives with type 1 diabetes. You know, I'm fascinated, and it's not something that I've been exposed to as a complication or a comorbidity, and it's just really fascinating to learn more about all these interconnections. So we do have quite a number of questions, and we'll try to tackle all of them. So thanks everyone for submitting your questions and for being curious while watching. So the first is, and to answer folks, just if you feel that you have something you would like to add, just feel free to dive in. We'll do a bit of a free-for-all, recognizing we just have the two of you. So first question is, how is NAFLD diagnosed, and how do you find out if you have it or not? So I think some is probably just looking for a bit of that kickstart or that first step of getting a diagnosis.
So traditionally, fatty liver actually was often not diagnosed, but nowadays I think if you take people that have risk factors for fatty liver, and the biggest risk factors, of course, are overweight, obesity, and type 2 diabetes or pre-diabetes, and but also people that have high cholesterol or triglycerides. Those are the people that are the highest risk. Probably the simplest way to diagnose is if someone has an ultrasound that shows fat in the liver, that's fatty liver, whether the liver tests are abnormal or not. Marianne, do you have anything to add to that?
No, not really. I mean, from an endocrinologist perspective, I will order liver enzymes on patients if they're normal. It doesn't rule it out, but if they are elevated, I may refer them on to a hepatologist for further investigation or for an ultrasound.
The interesting thing is in our pathway in Calgary, we found that about 50% of people had persistently normal liver tests that had fatty liver that went back over 2 years previous, and that the abnormal liver test did not correlate with how much scarring they ended up having in their liver. So it's, so we're learning a lot about how to approach these patients, and I think there's so much more that we need to understand about how to manage patients in a way that really funnels them to the right people, because usually the right person is not me.
The next question is to do a little bit with genetics, which was alluded to, a number of times as a potential risk factor. The question is, so here's a big one. I myself am type 1, my mom is type 2 and has been diagnosed with fatty liver disease that led to cirrhosis. Does that then increase my risk?
That's a very good question. I don't have a very good answer for that, but I mean, there are two different diseases, right? And one's an autoimmune disease, and although you can be a type 1 diabetic and also get insulin, you can also develop insulin insensitivity if you start to become overweight and have those issues. So you can have this mixed pattern of kind of like type 2, type 1, and Marianne would be the expert in that. I don't think that. Everything else considered, that would not place someone having type 1 diabetes as having the same complications that her mom had.
Yeah, I would agree. I mean, I think that you definitely can have type 1 diabetes with type 2 superimposed, and we do see it. We see bariatric patients that have type 1 diabetes and requiring high insulin doses and post-surgery aren't needing the same type of insulin amounts post-bariatric surgery. So definitely it does occur, but are you at the same risk if you don't have those other risk factors? I don't think so.
I have someone else who's wondering how this topic relates to quote unquote leaky liver.
I have no clue because I don't even know what leaky liver is. But when people get hyperglycemia, so increased blood sugar levels in the blood sugar levels, and they have NASH, or they don't necessarily have to have fatty liver. It changes how the cells that line the gut form a barrier. So normally the cells that line our gut are a very good barrier for bugs and products from bugs to getting through that are really not good for us. And so what happens is that when you get fatty liver, or you get high, like type 2 diabetes with high levels of sugar, and you start to get an inflammation in your body, which goes along with that, it affects how that barrier functions so that it becomes leakier. And it's felt to be that leakiness can drive more inflammation in the body, which drives all of those many of those complications that Marianne showed actually, and also drives worse liver disease.
Yeah, we don't talk about inflammation often as part of one of the risk factors, but I think that there is a significant amount of inflammation that's happening that does lead to increased insulin resistance, whether it's at the level of the gut. Definitely, it was one of the thoughts it is one of the thoughts with infectious liver disease, that the chronic inflammation associated with that increases insulin resistance and leads to increased risk of diabetes. And there have been cases where you treat their liver to treat their underlying infectious disease or liver disease, so their hepatitis C, and their insulin needs actually improve because there's decreased the thought is decreased inflammation. It's not exactly well known, but that's the thought.
This next question is probably specific to Mark, and it's to do with the graphic you showed of the sort of changing in color and structure of the liver. And it's someone wondering, can you fix the liver and revert it to a nice pink one, or will it forever be damaged? So
that's a great question, and so the liver is a fascinating organ in that you can take a normal liver and chop it in half and it grows back. And so it's the only organ that we have in our body that regenerates. So if the liver is given an opportunity, it regenerates. And so if you can remove the damage, then the liver can get better. But also, people used to think that scarring was permanent, but now we know there's something called remodeling, which means that if you take away the ongoing damage, then the liver is able to pull that scar tissue out, as long as it's not super well formed and super tight, if it's a loose scar tissue. And we know from other liver diseases, including people that have profound weight loss with bariatric surgery and things like that, that people can go from essentially a cirrhotic liver to a liver that looks normal. Is it totally normal? It's probably not totally normal, because there are some other issues that go along with it, and the predisposition to cancers and things like that. If they already had cirrhosis, so really bad scarring, that probably gets less, but probably doesn't go back down to normal. But the function and all those kind of things, and the sort of the more pinkiness as the fat leaves the liver, because it's the pink the yellow is the fat, and that's what's changing the color of the liver. It would go back to pink, yes.
That's fascinating. I didn't know that the liver was regenerative.
Yeah,
it's pretty amazing.
And so that's actually the basis behind a liver relating donor. So when people get a liver transplant, say you have advanced, unfortunately you have developed liver failure because of, say, NAFLD or NASH, and someone in your family or whatever can donate part of your liver. And when that liver is put in your body, that liver grows right to the same size that your liver was before. And the person that donated the liver, their liver grows right back to their same size their liver was in their body. It's quite fascinating.
Wow.
It's a miracle, actually.
We have someone wondering if blood sugars are controlled through medications despite still having sweets. Is there a negative impact to the liver? In other words, is it the level of sugar consumed or the amount of sugar the body needs to deal with that is most detrimental to the liver?
Well, that's I'll let Marianne take that, actually.
Yeah, that's a complicated question with a complicated answer. Definitely, I think if you're having increased simple sugars, sweets, etc., your blood sugars are going up. And depending on what treatment you're on, assuming, let's say you're on insulin, you're using more insulin, and basically you're actually causing the body to store more and the liver to store more. So it could potentially be harmful, and we don't know that. And I think that's one of the things that is different with some of these newer medications, is that they don't cause the body to store more. They cause you either to consume less or to get rid of that excess glucose through the kidneys. And so perhaps in those cases, it wouldn't. So I really think it depends on the type of medication you're on, and potentially it could cause more aggravation in inflammation within the liver and more fat to be accumulated.
There's a question to do with asking if liver disease could be underdiagnosed if liver enzymes may not be affected, as it seems like the ultrasound is done to only confirm the disease.
Yeah, so liver disease, we know it's underdiagnosed, right? And an interesting thing, I have a discussion all the time, because I think that if you go to most endocrinology practices, they say, I don't see much liver disease. Like, I don't see much end-stage liver disease or cirrhosis. And I think that's because endocrinologists are very good broadly at controlling people's blood sugar. And they're focused at it, and they're very good at it. And so their goals of hemoglobin A1C are relatively tight, and sugar control is tight. But when you move away from a specialist who's dedicated to that and move into more a sort of, I guess, into a more of a community setting, often the range of sugars that are allowable, that are okay, are broader, and the hemoglobin A1C levels are often higher. And I think as in those individuals that where we're more likely to see, because we know that progressive liver disease is related to glucose control, essentially, in type 2 diabetics. And so I think that's where we see a lot of more individuals that are going to be presenting with end-stage liver disease. And I can tell you, as a liver specialist, we're seeing many more people present now with liver failure, liver cancers, that are being driven by fatty liver disease, not by the traditional things like infectious hepatitis that we normally would have thought is the key driver.
So folks, I think we have time for probably one more question, then we'll have to wrap up. But there's one that, frankly, I'm curious about this as well, and I'll direct it to Mark. And it's, why is coffee good for liver disease? What's the do you know more about that?
Well, it's interesting. So caffeine broadly is beneficial to the liver in that caffeine stimulates a certain type of receptor that's very important for blood flow to the liver, and that probably is a beneficial effect of that. But it's more than just the caffeine, because it's actually, if you look at say caffeinated drinks that are not coffee, they actually they seem to have a benefit, but not the same degree of benefit as coffee. And in fact, there is even some evidence that certain ways of making coffee, like a drip coffee, seems to be better than an instant coffee. And so there's a lot left to be learned. But certainly, I think if someone likes coffee, I don't think there's a downside, unless they have a heart issue or a rhythm issue in their heart, to drinking more coffee, as long as they're not adding sugar to it.
It is really interesting. I'd like to, before we wrap up, just sincerely thank you both. This has been such an interesting conversation. I personally have learned a lot, and I hope the same is true for our viewers. And to our viewers, I'd also just like to say, if you have further questions, please feel free to visit diabetes.ca, or to contact us directly at 1-800-BANTING or info@diabetes.ca. I just, once again, really sincere thank you to Dr. Doyle and Dr. Swain, and I'll also hand it over to them to provide any more information on Canadian Liver Foundation.
No, absolutely. Thank you for that. It's absolutely a great conversation, very stimulating there. And again, for more information, I think both organizations provide quite a hefty amount of resources and support. For more information on liver disease and all types of liver disease, we have our liver.ca website that contains all the information about fatty liver disease and all the associated liver diseases that Dr. Swain was indicating and speaking about broadly. And we have also our email that all patients and caregivers and those who want more information to reach us. It's at clf@liver.ca. But again, liver.ca for additional information.
Okay, thank you, Em. And once again, thank you everyone for your time and for sharing that information. It's greatly appreciated, and take care, everyone.
Thank you so much, and thanks, Marianne. That was really a joy presenting with you.
Thank you too, Mark. I enjoyed it as well. It was great.
Bye, folks. Thank you.
Thanks so much.